All right, so in the interest of time, because we have a very full agenda today, we're going to go ahead and get started. Once again, welcome everyone. Thank you so much for joining us. This is the second session in our Congenital Syphilis workshop series hosted by NCSD. My name is Talia Parker, and I'm the Manager of Program Operations here at NCSD. So today we'll be hearing from our friends in Texas and New York City. We're very excited to have them here. Before we get started though, I wanted to do a few housekeeping notes. So just like last week, this is a Zoom meeting and not a Zoom webinar to allow for the breakout sessions that we're going to be having at the end of this session. So be sure to be respectful of this format. Please stay on mute until the end. When we have questions, if you'd like to come off of mute and raise your hand, you are welcome. But in the meantime, please feel free to put any questions that you have for the speakers in the chat, and I will collect them for the end of the presentations. Like I mentioned, we will be joining breakout rooms at the end of the session for about 30 minutes. So that will be an exciting opportunity for you to engage with your peers about the presentations, any ideas you may have after hearing the fantastic presentations. And then if you have any case questions that you brought today after my email last week, we are excited to engage with you around those as well. Just two more notes. This session will be recorded and shared on NCSD's website and through the STD Weekly in the coming weeks. So you'll have access to that then. And then finally, we will be putting an evaluation in the chat at the end of the session. So make sure to fill that out to give us your feedback on this. So without further ado, I'm going to introduce our first two speakers, and then we'll get started on their presentations. So first off, we have two speakers from Texas. Amy Carter is currently the Congenital Syphilis Coordinator with the Texas Department of State Health Services. She was introduced to congenital syphilis as a disease intervention specialist with Dallas County Health and Human Services, where she was assigned congenital syphilis investigations. While in Dallas County, she became the primary congenital syphilis investigator and was promoted to first-line supervisor. In this role, she was an integral part of expanding congenital syphilis activities to include a fetal infant morbidity review board for the Dallas-Fort Worth Metroplex and a congenital syphilis team. She worked closely with local providers to solidify partnerships between the health department, public health follow-up staff, and providers who offer services to pregnant people. In her current role, she works closely with a congenital syphilis epidemiologist to coordinate prevention efforts across the state of Texas with a focus on capacity and infrastructure building. And we also have Jessica Del Toro, who is a congenital syphilis epidemiologist for the Texas Department of State Health Services, where she initiates and conducts analysis on data associated with congenital syphilis, including examining surveillance efforts, epidemiologic trends, and public health follow-up efforts. Jessica first began working on congenital syphilis in 2017 with the San Antonio Metropolitan Health District as a disease intervention specialist, where she conducted follow-up for pregnant women with syphilis, CS investigations, and maternal interviews for Bexar County. Jessica currently serves as a core member on the fetal infant morbidity review boards on congenital syphilis in Houston, San Antonio, and Dallas-Fort Worth areas. So thank you both for joining us today, and I'm going to go off of mute and allow you to share your screen, and let's get started.
Good afternoon, everyone. Thank you for joining Amy and myself today to learn a little bit more about congenital syphilis in Texas. So today we are going to be covering congenital syphilis in Texas to include our data, pregnancy ascertainment, congenital syphilis investigations, our partnerships, as well as case review boards and provider education. So looking at what congenital syphilis looks like in Texas, in 2018, Texas reported 371 congenital syphilis cases and had a case rate of 91.9 cases per 100,000 births. Nationally, 41 out of 50 states reported at least one case of congenital syphilis, and the majority of the cases came from the South and the West. Texas ranked first in both case number and case rate, with 50 Texas counties reporting at least one congenital syphilis case. So looking at our case numbers in Texas for early syphilis among women of childbearing age and congenital syphilis, with early syphilis consisting of primary, secondary, and early non-primary, non-secondary cases. The increase in cases of syphilis in women are associated with the increased cases of congenital syphilis. So our congenital syphilis cases have consistently been increasing since 2016. And in 2018, not only did Texas report the highest number of congenital syphilis cases since 1993, but Texas, the congenital syphilis case rate was triple the national average. So this map of Texas shows the proportion of congenital syphilis and syphilis among women of childbearing capacity in 2018. Our high morbidity areas are Houston, Dallas, San Antonio, and Public Health Region 11. In 2018, Houston had the highest number of CS cases at 104, with San Antonio having the highest case rate at 217 cases per 100,000 births. This was 7 times that of national rate. So now taking a look at some demographic information for women delivering infants with congenital syphilis. At the time of delivery, nearly half of the mothers were 25 to 34 years old, and 90% were under the age of 35. And so nationally, syphilis disproportionately affects women of color, and Texas does mirror that trend, with approximately 9 out of 10 infants with congenital syphilis being born to Hispanic or Black or African American Texan women. And while Texas is technically in the South for the Department of STD prevention, we do border the West, and we can see similar trends in our reasons for our congenital syphilis cases. So for treatment among women delivering an infant diagnosed with congenital syphilis, more than 3 in 5 had inadequate treatment, being treatment that was initiated less than 30 days prior to delivery, or inadequately treated for their surveillance stage of syphilis, or they were just untreated. And fewer than 1 in 6 had adequate treatment, so initiating 30 days prior to delivery or receiving their appropriate treatment based on their surveillance stage. And over 70% of women, of mothers did engage in some level of prenatal care. 25% did not enter prenatal care until the 2nd trimester, and 17% had no prenatal care at all. So just a quick review of the Texas Public Health Follow-up and Surveillance staff. So Texas has 18 jurisdictions that serve 254 counties. At the local and regional health department, there are approximately 110 disease intervention specialists throughout the state, and they also have varying amounts of surveillance staff. So, and then here at central office, we do have public health follow-up consultants, as well as project coordinators, a public health nurse consultant, program managers, ICCR clerks, epidemiologists, data surveillance coordinators, and surveillance program managers as well. And this all covers a population of about 28.7 million. So Texas was the recipient of a supplemental STD program funding for enhanced congenital syphilis response in 2017, with 8 other project areas. This did allow for hiring 2 additional staff, the congenital syphilis epidemiologist, as well as the congenital syphilis coordinator. And our key activities were to improve pregnancy ascertainment, as well as improve or implement case review boards around congenital syphilis, implement vital statistics matching, as well as strengthen our key partnerships. So overall, Texas wanted to provide guidance to our local and regional health departments when we were doing capacity building. This started with establishing monthly calls with our high morbidity areas. So that included Houston, San Antonio, Dallas, as well as Public Health Region 11, which borders the United States and Mexico border. And in 2018, those regions did account for 75% of our congenital syphilis cases in Texas. We then added monthly calls with 5 other jurisdictions who reported 10 plus cases in 2018. And we also started to develop tools that those local and regional health departments could utilize, as well as providers. So we established the Congenital Syphilis Program Operating Procedures and Standards that was published on our DSHS, or the Texas Department of State Health Services website, in early 2020, along with the congenital syphilis classification workflow. There it is. That is our case classification workflow. It is a clickable. So our CS investigators or DIS can utilize this when they are trying to determine a case classification for congenital syphilis. And moving on to pregnancy ascertainment, one of the first practices that we wanted to improve on as a result of supplemental funding was to improve pregnancy ascertainment. We did train our DIS to feel more comfortable in ascertaining pregnancy status among persons of childbearing capacity. So some questions that we wanted to include or really break it down was, what are your plans regarding future pregnancies? When would you like to become pregnant? And what referrals would you like to prevent pregnancy until then? So some questions that we trained on asking was, when was your last menstrual period? What medications are you taking? This was to help ascertain on any contraceptive methods that may be utilized, as well as incidental antibiotics that could affect RPR titers, as well as PrEP status and more. How many children do you have? So obtaining the ages of the children was, we were able to determine whether or not there was any previous children who may have been exposed to syphilis. It also assists in determining fathers and children of for potential additional partners. And when was your last pregnancy? So this is was a required question that we did train on for our DIS to ask in order to assist in possible missed syphilitic stillbirths, or assist in staging by obtaining non-reactive test results from prenatal care from previous pregnancies. So Texas is using over-the-counter pregnancy tests in field blood kits, and DIS are giving them to clients to self-report pregnancy status if they are unsure of their status. Their pregnancy status, and if a client does report being unable to get pregnant, but is determined to be of childbearing capacity, then the DIS is just recommended to document that. Additional questions would be, would you like to become pregnant in the next year? And this really helps on the DIS giving the client proper referrals or resources. So some resources that may be provided include Medicaid enrollment and referrals to public health STI clinics, low-cost clinics for access to contraceptives or women's health, as well as prenatal care. So continuing our capacity building along with pregnancy ascertainment, we did want to increase pregnancy status reporting in our laboratory data. So we did include in our laboratory section, we do have notes where it can be entered on whether the lab was due to a encounter for pregnancy, such as first prenatal visits or a pregnancy test where a syphilis test was done at the same time. And then after, if it is indicated that it was due to an encounter for pregnancy, we have an assignment where it does show a new STI positive result and pregnancy, where our DIS then later enter the pregnancy status into the system, and it does ask for the number of weeks pregnant at the time that the lab was collected. It also shows the approximate due date, and this goes into our congenital syphilis investigation pending workflow, where our field staff, DIS, and surveillance are able to track clients until their expected due date. So if they do receive a prenatal care result, then they know to go back and look through the workflow to ensure that reporting was done of the delivery labs, and that the congenital syphilis investigation can get started. So looking at maternal treatment adequacy, we do train in record searching, so documentation of inadequate treatment for syphilis case classifications, reviewing the most recent case classification in case of the need for additional treatment. So by this, was there a missed signs and symptoms documentation? Was this closed as early non-primary, non-secondary, when it really should have been closed as a late or unknown duration syphilis classification? So with this, we do encourage RDIS and surveillance just to do that additional record searching, reviewing all historical syphilis diagnoses to ensure adequate treatment was provided at the time of diagnosis, as well as reviewing historical titers, just to ensure there was no checking for any missed investigations based on sustained two dilution titer rises with the absence of treatment. So really just looking at the history of testing, and then asking how do we prevent future congenital syphilis cases when there was historically adequately treated. So with this question, we did decide to implement a follow-up field record, which is a treatment restart field record. So this is following up on historical inadequate treatment. And the purpose of this was to reduce the number of persons who deliver infants that are classified as congenital syphilis cases due to historical inadequate treatment. And so with this follow-up field record, our surveillance staff is able to review positive labs that may be received either during prenatal care or prior to becoming pregnant, routine STI screenings, and reviewing their historical diagnoses, checking for to make sure that there was adequate treatment. And at that point, if they do determine that the client was inadequately treated and that person is of childbearing capacity, they will initiate an F4 field record in order for treatment to be restarted, in hopes of adequately treating to prevent a future congenital syphilis case. So these do take a high priority in regards to phone calls and field visits, especially since there's new locating information as a result of this new laboratory report that was received. One recommendation and feedback that we did receive from our sites was that if a person is in prenatal care when this field record is initiated, then it really assists in them establishing a relationship with their prenatal care provider in the event that they don't receive a report from labor and delivery when the client does deliver. So reviewing investigations, the congenital syphilis investigator completes the STD 126 and the question package in Maven. It then goes through supervisory approval, which then comes to central office, and either the congenital syphilis coordinator or epidemiologist will conduct the final review. We also have a central office review board where we discuss cases where we are trying to determine the case classification, where there may be some questions that we have. We'll bring in our public health follow-up, our public health nurse consultants, as well as surveillance staff to discuss what we believe that certain cases should be classified as. Central office may reopen investigations for additional follow-up on mothers and infants. We do modify case classifications from time to time. In the event that the maternal morbidity is changed due to if the case classification was previously stated as early, non-primary, non-secondary, but we found that there is no evidence to support that classification. And we will also assign additional follow-up if infants require additional follow-up testing or treatment. So something else that we implemented in probably the past 3 years was that we did establish a congenital syphilis tracker that we do require our jurisdictions to return to us at the end of the month. It's uploaded to a secure file sharing database. We asked them to include pending investigations, and this was initially implemented due to the delay in reporting in MAVEN that we were going through. But since we have added tracking for other socioeconomic factors such as prenatal care, substance use, social factors, as well as COVID-19 results. So this is the tracker where we look at different components of an investigation that we are not able to collect in MAVEN. And vital statistics matching. So programs receive quarterly vital statistics matches from the congenital syphilis epidemiologist via our secure sharing database. We do have asked that 90% of syphilitic stillbirth probable and confirmed cases to be submitted within 45 days of the jurisdiction being notified, and 85% of cases where the case classification is no case to be submitted within 60 days of notification. And so by doing with this component, we are able to match birth data with maternal syphilis morbidities to determine if there is any potential missed congenital syphilis investigations or that were previously unreported. And partnerships, we have recently partnered with Medicaid to conduct matching using Medicaid or CHIP recipients, and MAVEN to locate additional testing and treatment information, as well as to determine treatment adequacy. We also partnered with birth defects, epidemiology, and surveillance, where we link cases of birth defects from the Texas Birth Defects Registry with various maternal and neonatal diagnoses from MAVEN. And this is to explore the extent to which a birth defect affected pregnancy are also in the MAVEN surveillance system. And on cross-jurisdictional reporting, we got to know our neighbors to encourage local jurisdictions to talk to each other, establish an out-of-jurisdiction report policy that is consistent with timely reporting, as well as to establish a point of contact in the neighboring states. And with that, I'm going to pass it over to Amy Carter, who's going to cover a little bit about our case review boards.
Thanks, Jessica. So in Texas, we do have 3 fetal infant morbidity review boards. We use these review boards to review our highest priority cases and in our highest morbidity jurisdictions to look for missed opportunities for disease intervention, barriers to care that may be leading to our congenital syphilis reporting. Again, these account for 75% of the cases that Texas reports. Houston and Public Health Region 6-5, that was established in 2015. San Antonio and Bexar County was established in 2018, and Dallas-Fort Worth is the newest one that was established in 2020. And so they meet quarterly and review specific cases. Next slide. Yeah, so our case identification, we try to review as many cases as possible, but with the large number of cases, we do prioritize the cases for review into specific categories. So we start with our syphilitic stillbirths and perinatal deaths, followed by our confirmed cases, any symptomatic cases that we may have, and any other probable cases. The local jurisdictions work with our central office staff to identify and review the cases between 90 and 120 days of birth. We also prioritize these by highest, which would be our syphilitic stillbirths and perinatal deaths. Our higher cases are confirmed cases, and our high priority cases are symptomatic cases. There are some components that go into these reviews. We use enhanced medical chart abstractions, where we review all points of care for the pregnant person and the delivery parent. So whether it's prenatal care, pre-pregnancy care, any intrapartum care, any postpartum care, and any pediatric care that the infant may receive. We also have maternal interviewers, which are specialized DIS, who are congenital syphilis investigators as well, who go out and use a Texas adopted fetal infant morbidity review maternal interview, which takes about 2 hours to talk to the mom and get her experience. We then have our case review, where we de-identify everything and review in a non-judgmental way to identify our community action items to meet our community needs. And through these case review boards, we have noticed some trends across all 3 of our boards, which include our mental health, housing instability, substance use and abuse disorders, transportation, involvement with corrections, domestic and intimate partner violence, prior involvement with child protective services, some implicit biases from providers, and providers not following testing laws. We definitely recommend, if you do any of these fetal infant morbidity boards, to start looking at these trends about a year after the first set of reviews, so you can sort of get those trends going. From those, we start to see our ongoing provider education that we've started to implement, which includes our adequate syphilis treatment, our 3rd trimester laws that have been changed in Texas to include our 28 to 32 week time frame, appropriate evaluation of infants. Houston did a legislative pilot program to allow for transportation of other minor children under Medicaid transportation to help get moms to the prenatal care, and adopting routine syphilis testing at pregnancy crisis centers was implemented in San Antonio. So with our provider education being a large piece from our FEMR boards, we encourage provider reporting of persons who are pregnant, explain that the health authority additional syphilis laboratory results and treatment history may be available, and that they can assist in obtaining out-of-state history. A lot of times what we were seeing was noted as just patient stated, they said they got treatment, they were treated out of state, but there wasn't any actual documentation to back that up within the medical chart. So building those partnerships between our health departments and our providers, they're knowledgeable about the local, national, and state trends, also about the Texas pregnancy testing laws, excuse me, which require testing at the first prenatal visit, 3rd trimester, no sooner than 28 weeks, and at delivery, and following the CDC recommended treatment guidelines. Through this, we also developed some flow charts for assisting providers in making treatment decisions and evaluation decisions with infants who may be affected by syphilis and congenital syphilis. And it's a 2-part evaluation that can be walked through in just a little decision tree that we have that is available on our website as well. And it gives you kind of where those fall into. But thank you guys so much for listening to us talk today.
Thank you so much, Amy and Jessica. And I know we have a few questions in the chat. We're going to move on to our next presentation, but Amy and Jessica, if you want to answer any easily typable responses in the chat, that would be great, but we can get to the rest of them at the end. But for now, I want to introduce our next two speakers from New York City. So Robin Hennessey has MPH has over 25 years of experience working in the field of public health, specializing in STD HIV prevention. Since 2004, she has been employed with the Centers for Disease Control and Prevention as a field assignee to the New York City Department of Health and Mental Hygiene, Bureau of Hepatitis, HIV, and Sexually Transmitted Infections, where she directs the STI surveillance, investigation, and partner services teams. Ms. Hennessey holds an MPH from Columbia University, Mailman School of Public Health, and a BA from New York University. And Samantha Malvasio has over 5 years of experience working in the field of public health, specializing in STD HIV prevention. Since 2017, she has been a disease and intervention specialist for the New York City Department of Health and Mental Hygiene, Bureau of Hepatitis, HIV, and Sexually Transmitted Infections. That's a mouthful. She has been working as a congenital syphilis prevention investigator since September 2021. Ms. Malvasio is currently finishing her MPH at Hofstra University School of Public Health and has her Bachelor of Science in Community Health from Hofstra University. So I'm going to share my screen and feel free to take it away, Robin.
Good afternoon. Thanks everyone for joining us today. I'm going to be wearing my New York City Department of Health hat during this presentation. And we are going to be talking about congenital syphilis in New York. Next slide. So just a little overview of what we're going to be talking about today. We will be looking at some New York City data, some highlights from our New York City Health Code, which might answer some of the questions in the chat, some of our programs and partnerships, and what I want to highlight mostly is the congenital syphilis prevention investigator staffing model. And Samantha is going to give us a little case study of one of the cases she's been working on recently. Next. So I can't start out a presentation without some data. And New York City is a city of 8.5 million people, and we are a high morbidity jurisdiction, as you can imagine. Even with the coronavirus pandemic in 2020, which certainly led to lockdowns and delayed healthcare seeking, we still saw increases in primary and secondary syphilis in 2020 compared to 2019. Next slide. This is one of my favorite slides, 80 years worth of primary and secondary syphilis case surveillance rates per 100,000, starting back in 1940 up to 2020. There's a lot of beautiful peaks and valleys, all with a story of their own. But I'm going to focus in on the last 20 years, starting at about 2000, where we had case rates of about less than 2 per 100,000. Next slide. So this slide looks at those last 20 years, and you can see that in 2000, the gender breakdown between male and female was practically the same. And just a note that when I refer to male or female during this presentation, that is generally the gender that was reported to us via case reports or laboratory reports. So we don't really get sex assigned at birth or gender identity for most of these. So that is just my little caveat. So you can see that this has been largely a male epidemic in the last 20 years. And the female line has been hugging the zero for quite some time. But if you check out 2016, we do see a little bump, and that has been sustained for the last couple of years. Next slide. This slide is the actual number of cases among people reported as female over the last 20 years. And as you look more closely at 2016, we had a doubling of those cases. And in the last 4 or 5 years, it has been a steady increase. And keep that line in mind because you'll see it in the next slide. In this slide, we can see in the blue bars the number of congenital syphilis cases. The purple represents stillbirths by year. And then the line, which is on the right-hand axis, that is the case rate of primary and secondary syphilis among females. And again, we had that jump there in 2016, and it has been steadily increasing, as well as the cases of congenital syphilis have been increasing from 2018 and stable through the last couple of years. And spoiler alert, 2021, we are going to have more cases than 2020. Next slide. So I decided to take the opportunity to just highlight a couple of New York City Health Code things that we've been able to put through that have really been helpful for our congenital syphilis prevention program. And I thought that I would share these as ideas for other jurisdictions and how they might want to take advantage of that sort of infrastructure change to assist. Back in 2006, electronic laboratory reporting was mandated in New York City. So we have a very robust system. And taking advantage of that, in 2008, we asked that laboratories report pregnancy status if it is known and if it's related to the condition, such as syphilis or hepatitis B, et cetera. We learned that many laboratories were a little concerned about reporting pregnancy status if they themselves did not have a pregnancy test on file for the patient. And so we amended the health code again in 2014 to say pregnancy status if known and or probable, meaning that if a laboratory knew that the test was part of a prenatal panel, they could report to us prenatal panel, and we could ascertain that that was a probable pregnancy, and then the lab could feel comfortable reporting that off to us. In 2019, we mandated third trimester screening for all pregnant people. And this is in addition to New York State public health law, where there is required screening at the first prenatal visit and at delivery. So in New York City, there is mandated screening at first prenatal visit, third trimester, and at delivery. And then finally, we have plans to designate syphilis in a pregnant person as an immediate report condition for providers. Currently, they have 24 hours to report, and they can do that by paper form or the electronic portal. Immediate report would mean that they had to call someone in the health department to report that case. Next slide. So a couple programs and partnerships that I just wanted to share. In New York City, we created a congenital syphilis work group back in 2013, sort of a precursor to the mortality and morbidity review boards that CDC now recommends. This was sort of a group of internal folks in our programs. It was surveillance, epidemiology, partner services, clinic affairs, and our leadership. And we originally started this work group mostly to pull together our policies and our procedures, find out the gaps. Did we have any conflicting policies? And it slowly became more of a review board in that we were looking at each individual case. We were discussing the opportunities for prevention and what kinds of interventions we could implement. And one of those interventions was our social work program, which we implemented in 2017. So the STI program is lucky to have social workers as part of staff in the sexual health clinics. And we were able to partner with them to follow up with the people that we have diagnosed with syphilis as well as pregnancy. And the social workers try to reach out to those patients a couple times during pregnancy. They offer referrals to prenatal care. We were able to purchase baby basics books. That is the little picture on the side, and the social workers are able to get those books to our clients. They provide social supports, discuss sex partners, offer counseling, etc. And then probably the most important piece of this intervention is reminding those people to get retested for syphilis at 28 weeks. Next slide. Adding on to that, we partnered with our Bureau of Maternal and Infant Reproductive Health in 2018. And we learned about the various programs that they have available. There's the Nurse Family Partnership, which is like a 2-year program where a nurse visits first-time parents starting before delivery and then 2 years out. And I think it's like every 2 weeks. It's a really amazing program. And so we're able to refer our clients to that program. Additionally, we've provided trainings in congenital syphilis to the nurses who go out and speak to those clients. Cribs for Kids is one of our more exciting programs. You know, we're able to now provide a pack and play with sheets and sleep sacks for the families who have newborns. And this is not just people with syphilis, but anyone who has a newborn who could use one of these cribs. And so that's been an exciting partnership, as well as the newborn visiting program. And that's restricted to a couple of neighborhoods, but we're still able to make referrals there as well. Next slide. So right now I'm actually going to switch gears a little and talk very specifically about a program that we implemented last year. And I wanted to just talk about the details and how we arrived there. So in the fall of 2019, we were lucky enough to have an EIS officer in New York City who decided to evaluate our congenital syphilis prevention system as part of their required evaluation. At that time, the EIS officer identified a prioritization practice in one of our programs in the Case Investigation Partner Services team that was recommended for more broader implementation. And that practice was that all syphilis investigations among people reported as female were being streamlined to a single DIS. And considering that that's only made up 6% of all of our investigations, that seemed to make a whole lot of sense. And we were really excited that this was identified so that we could implement it system-wide. Next slide. And that's when our collaborative program planning began. Congenital Syphilis Prevention Investigator, or CPI, was a name chosen by the DIS and the folks who do this case investigation work. We identified some short-term goals, which would be to increase the experience that our CPIs have with conducting and documenting investigations among females and infants, and then have a greater and more timely referral of those pregnant people to our social work program. And some of the longer term goals would be to improve our timeliness and adequacy of treatment, get more sex partners identified, and then increase third trimester screening, which would long term, hopefully, avert more congenital syphilis. Next. So in January of 2020, when we were all still innocent, pre-COVID, we had an in-person staff meeting with 100 people. We introduced the idea of this CPI program and used the opportunity to elicit feedback. We conducted a staff survey to really get an idea of what folks thought about this plan. Luckily, a high percentage of folks agreed or strongly agreed that this model was an important change and it made sense. We were also really excited that over 50% of the folks who responded to the survey thought that they would be interested in being a CPI. Some of the barriers that were identified were remembering how to do a CS investigation, concerns about burnout, and worrying that it might be stressful dealing with high priority cases all the time. Next. There were also additional items that we collected on our survey. Specifically, we wanted to know what sort of training that CPIs felt, or that our staff felt they would need to become a CPI. And one of those, the themes were that folks were interested in syphilis in pregnancy and congenital syphilis. And you can see some of the direct quotes from the survey of what they were interested in. They identified wanting more training in congenital syphilis interview protocol and chart reviews, specifically need to know what information needed on the baby. They wanted more on pregnancy and prenatal care. And finally, looking for some skills building in patient counseling, knowing that pregnant people or people who could become pregnant might have different kind of counseling needs than men, which is what the staff had been focused on for so long. Next slide. So this is just a sort of timeline as to how we pulled off our implementation. We started planning, and that was leadership and surveillance, the case investigation team, social work, discussed how to operationalize such a program. And the supervisors chose 3 people, 3 of their GIS to be CPIs in each of the 8 regions in New York City. We had originally thought we would take a primary and then a backup. However, this was COVID by then, and so many of our staff were being activated for COVID follow-up and case investigation that we decided to go deeper and choose 3 people to make sure that we had enough coverage. We did a kickoff meeting in May of 2020 where all the CPIs, the supervisors, social workers, everyone was involved. And at that time, we did a pre-implementation survey on knowledge, attitudes, and practices. During this meeting, we explained our model, how CPIs would be assigned their work, and we went live on June 2020. We emphasized the social work partnerships, as well as explained all the trainings that we would be providing and that we'd be requesting a lot of feedback. Next slide. So between May and December 2020, our CPIs had a variety of trainings. Some of these were webinars from CDC, the Congenital Syphilis Surveillance Infant Medical Abstraction, as well as evidence gathering and case reporting. Adult syphilis staging was also one of the CDC webinars that they attended. Our social work team did a training on teaming up to stop congenital syphilis, and we also had a training on documenting syphilis and congenital syphilis in MAVEN. Next slide. We also had a post-implementation survey on knowledges, attitudes, and practices in March 2020 so that we could get some comparison. Additionally, we hired a consultant from Midwife Life Consulting. And this group worked with our CPIs, did a lot of focus groups, qualitative interviews. From those interviews, did training development and program assessment. And you can see listed below some of the trainings that were provided. Additionally, one of our sexual health clinic OBGYNs was able to provide an additional training on prenatal care for our CPIs. Next slide. So we do have continuous program updates and improvements in fall of 2021. So about a year and a half after the program began, we decided to rotate the primary CPI out and pull one of the secondaries or backups. And then we implemented monthly regional meetings with both CPIs and social workers. And we've implemented quarterly all-team meetings, which we actually have to start. And then we have a couple of ideas of how to move forward with new messages to incorporate, one of them being universal Hep C screening recommendation for pregnant people. So we're going to add that message to our work, as well as signs of postpartum depression and hypertension. Next slide. So some outcomes, and then I promise I'll stop talking and let Samantha. This is just a comparison of our survey pre-implementation and post-implementation. And this was just measuring people's confidence and knowledge about particular topics. And you can see that there were improvements in almost all areas. Case definition for congenital syphilis went from 76% up to 93%, and comfort with conducting a syphilis investigation for target population, that went from 88% to 100%. So we think that the CPIs have improved their confidence and capacity to do this work. Next slide. So these are just a couple of outcomes that we wanted to measure. The first were things about documenting particular items in our system. So what we see here is the pre-implementation data. And next slide. And as you can see in the post-implementation, we've seen improvements in all of these areas: documented estimated due date, prenatal care date, et cetera, et cetera. Next slide. And these are a couple more outcomes: timeliness of treatment, investigation, et cetera. Next slide. And then in our post-implementation, you can see that we had improvements in all of these areas as well. Next. So some of our successes, I think, really came from that this program idea was actually came from the people who were doing the actual work and had an idea about how to do this successfully. We engaged staff in a variety of ways. I think the outside evaluator has helped because it allows staff to talk to someone who's not their boss or supervisor. And, you know, we have dedicated folks, just like everyone else, who are going to make it work no matter what the situation. Some of our challenges were that, you know, we had really great ideas about having these off-site retreats and in-person team building where we were going to, you know, buy nice food for the DIS. And of course, COVID changed all that, and we had to do all of these things virtually. It's also worth noting that, you know, could this program actually increase like a higher burden for the DIS who now have to take on this work? And then just a few limitations. You know, did supervisors choose their high-performing DIS to be CPIs? Probably. So there is a question as to whether this model would work if it were chosen at random. And just to remember that our data are preliminary, small samples, and there's always a COVID effect on everything, and we won't know what that is for a while. Next slide. So I'm going to now introduce Samantha Malvasio, who is a congenital syphilis prevention investigator, and she is going to share one of her recent cases. Next slide. So just as by way of background, our case investigation partner services team conducts over 12,000 syphilis T1 reactors investigations a year. We have 8 geographic regions, and Samantha oversees the area of Central Harlem and Bronx. She's been a DIS for 5 years. And while she was a backup CPI, she did attend all the program meetings and trainings and participated in the evaluations. And then she became a primary CPI in September of 2021. And now I'm going to be quiet and turn it over to Samantha.
Perfect. Thank you, Robin. So again, my name is Samantha Malvasio, and I am a disease intervention specialist for the Central Harlem Sexual Health Clinic. And this is my case. I received this case on December 21st. It was a 19-year-old African-American female. The RPR was from December 15th, and she also had a positive confirmatory test. On the following day, December 22nd, I was able to contact the facility. and spoke with the nurse, and I learned that she had a previous history. In April, she was a 1-32 positive confirmatory test. And at the time, she had no signs or symptoms, and also was treated with 2.4 million units. And her titer had fell to a 1-8 in August. And this was something that wasn't reported to the New York City Department of Health. I had to find this out through the nurse. I also learned that she was 23 weeks pregnant at this time, HIV negative, and her last STI screening was from 2019. No previous syphilis testing. And usually when providers do the panel for STIs, they don't do syphilis unless they have a sign or a symptom. And usually some of these women that I do work with, they do not know what syphilis even is. So they can't even ask if they, want to. Next slide. Okay, so on December 22nd, I was able to contact the patient. Patient was at work, very distracted. She's a young girl, she babysits children, so it was a lot going on. I learned that she was at 24 weeks pregnant at this time. She was receiving prenatal care. I wasn't experiencing any symptoms, and she did not seem to still understand what syphilis was. So I went over that. She just knew that she received treatment in the past. And then I was able to explain to her, the seriousness of the situation, and describe the need for her partner to receive treatment. And so I could have his information as well, so I can link it to the case. She was hesitant to share the information, but I still referred her and him to our telemedicine hotline and advised her to get treated at our sexual health clinic immediately. And I also advised her that I would be contacting her daily until she received the treatment. And sometimes you have to be relentless. Next slide. So on December 23rd, I checked the email. Her patient still didn't call telemedicine hotline as advised. Instead, she arrived to the sexual health clinic, and they already had stopped taking patients for the day, so she wasn't able to be treated. December 27th came, patient went to a different provider and was retested instead of receiving treatment. And now her titer rose to a 1-64. So now you see the 4-fold increase. Definite need for treatment at this time. And January 13th comes around, and patient went to a different facility and was finally treated. And I was able to speak with the PA and go over her previous labs and for her to receive treatment. And patient at this time was also receiving prenatal care at an entirely different facility. And they were aware of her test results, but she still didn't receive treatment. Next slide. So some of the challenges with this case was that, April and August encounters were not reported to New York City Department of Health and Mental Hygiene. So that definitely caused a barrier where I had to do some research. The patient also did not drive. So this was another barrier, getting rides with her boyfriend. And, she had to take public transportation, which who wants to do at all in a pandemic, but also she was pregnant. She still didn't really understand the importance of receiving the treatment. And I think that shows with how long this investigation went on for without her being treated. And also, she's trying to make ends meet. She's a young girl. Her partner's 17 years old. And, she had, other issues that were preventing her to take this as her highest priority. She was working all the time, so she couldn't go to the clinic. And I see that a lot of times with my cases. And this case definitely required over 20 patient encounters, calls, texts, home visits, even if it was good morning. Are you going to the clinic later? Or Happy New Year? Are you going to the clinic tomorrow? Definitely a lot of follow-up. And, she visited so many different facilities with no continuity of care. Next slide. The successes though, she was treated finally. Now, after all this investigation and interviewing and speaking, getting to know her, she does understand follow-up is needed for her and her newborn. Finally, as of yesterday, I was able to get her partner information, which is going to be an uphill battle, but we'll get to that. Referred her to the social work program for additional support, referrals, and the free crib program. And also, during COVID, we were all issued a city cell, and that definitely made it easier for me to build a relationship with the patients. Everyone likes to text, but definitely the younger generations love to text. So it was great. Next slide. And my thoughts, I received so many different trainings, being a CPI, and definitely the trainings were dedicated to working with these pregnant females. One training in particular that I definitely enjoyed was from Midwife Life Consulting. where Miss Odessa, she's actually a doula. And it also showed that there's like a growing body of evidence that proves that birth doulas are a promising strategy for improving health outcomes for women of color that are expecting. So that was a big takeaway as well. Also, we discussed how socioeconomic barriers can play a major role in someone's health journey. Living in high poverty neighborhoods limits healthy options and makes it difficult to access quality healthcare and resources that promote health. Access to quality healthcare is critical to a mother's health before, during, and after pregnancy. In this case, and so many others, it is obvious that these factors definitely play a role in healthcare and in the lives of the women that we serve. And lastly, I want to say definitely representation matters in situations like this. You know, I believe seeing myself in them and these young women seeing someone that looks like them caring about their needs, I believe goes a long way in maintaining this health equity that we, promote for our patients. And definitely the CPI program and the social workers with our bureau are dedicated to eliminating some of these barriers and promoting better health outcomes for the patients that we serve. Next slide. Oh, and thank you. Thank you, everyone. Thank you to my bureau and all my supervisors. And thank you, Robin. And thank you for giving us this platform to present our case. Thank you.
Wow, those were amazing presentations. Thank you to our speakers so much. I learned a lot and have a lot of thoughts, and I'm sure a lot of you do too, which is why I'm excited that we have the opportunity to do some breakout sessions today. So I know there were a few questions in chat. It looks like Amy and Jessica were able to answer some from their presentations. Robin maybe can answer some after the fact, but I want to get into breakout sessions.